All right, Andrew, the mic is yours.
Okay, in full Curton fashion, I've named the case Occam's or Hickams. This is a 64-year-old patient I met further along in her course, but who initially presented to the outpatient setting for prolonged fatigue. She says she had a brief, quote, GI bug lasting 2 days with marked improvement in nausea, vomiting, and diarrhea over those 48 hours. But over the course of 2 weeks, she continued to feel fatigue, so decided to see her PCP. She says the GI bug began while she was vacationing in the southern US, where she was walking in the woods. She wasn't aware of any tick bites. Her whole family actually got sick with a similar illness. However, everyone else recovered except her. The review system is otherwise positive, only for a sensation of increased thirst. After the resolution of her GI symptoms, she's not had any fevers or night sweats. Labs were notable for a sodium of 139, a K of 5.5, chloride of 106, bicarb of 25, anion gap of 8, glucose of 92, BUN of 64, creatinine of 6.5 with a baseline of 1 a few months prior, calcium of 8.5, phos of 5.1, and the CBC showed a white count of 10, hemoglobin of 15, platelets of 400. LFT showed albumin 3.9, total protein 6.7, alk phos 159, AST and ALT were both 20, and the bilirubin was normal. So for these metabolic derangements, she was subsequently admitted to the hospital. That's the end of this aliquot.
Oof, fire, double fire. Wow, what a start, Shema. What are your thoughts so far?
I just want to clarify one thing. GI bug. What can I understand of it?
Oh yeah, so it was really just nausea, vomiting, diarrhea that was very acute onset, and then the symptoms got much, much better over the course of 2 days.
Okay, now I understand. Thank you. So basically, seeing we have a 64-year-old patient presenting with fatigue and these GI symptoms. So when I hear fatigue, it's a very unspecific chief complaint, but basically common things being common, you think of any systemic viral infection where patients can present with fatigue, also anemia, also when patients have endocrine disorders, for example, like hypothyroidism, also sometimes patients who have some psychiatric disorders might also feel fatigue, and also if they have any kind of consuming disease like a malignancy. And the nausea, vomiting, I see relieved. And looking into the labs, could you, I see the creatinine is elevated and the BUN. I don't know how the BUN creatinine ratio is, and the patient had nausea and vomiting, because basically whenever I hear this, I'm concerned of something like volume contraction, and we see that the patient has an, I didn't calculate the Bun-Crea ratio, but I think it's 10, right? Okay, no, because I would have expected an elevated bone-crea ratio if it was a pre-renal problem. So I could also think that there might be some kind of an intrarenal process ongoing. And the elevation of this creatinine could give me a clue that this is less likely to be post-renal. We learned from Rabi, if a patient is presenting with elevated creatinine in an acute setting, you would usually expect a very high creatinine. But with this creatinine, I would also like to ask you how the baseline was. That's an important question. But yeah, because I still don't know whether this is an acute process. And I see the potassium is being elevated slightly, but it's still, I learned from a nephrologist, if the potassium is 5.2, you would actually start to treat. And otherwise, I still have to sort myself. What do you think, Charmaine?
Beautiful, Shema. Yeah, I think you nailed it by focusing on that creatinine and putting it at the center of the gravity of this case. And as you mentioned, the fatigue and everything, it's hard, it's very non-specific. So the question is like, what do we have to hang our hat on? And I think like that creatinine is quite impressive. So the question for you, like as you think about like when we see an elevated creatinine, yes, to know if this patient has underlying CKD or not is going to be important because again, the delta here is important. Is this someone who didn't have any chronic kidney disease, any issues, and his creatinine went from like 0.8 to 1 to 6 in a matter of an acutely, subacutely? I think that is a big question to know where the patient's baseline is. The question is like, she sounds like she has some sort of a gastroenteritis symptoms that has passed. And from that perspective, sounds like she's doing better. However, she has this lingering fatigue. The question, and yeah, you're absolutely right. Whenever we think about that history, in the setting of poor PO intake, diarrhea, or vomiting, you often think about contraction and hypovolemia causing prerenal AKI. However, like if this is acute, that rate of creatinine is quite impressive to just be explained in my mind by just contraction if she has no history of CKD in the past. So whenever I think about AKI, I think it's like the first schema most of us ever learned in med school is like pre-renal, post-renal, intrarenal. I often think about like post-renal and pre-renal as like hemodynamics effect, right? Like the kidney itself is fine. If you take that kidney, put it in another human, that kidney is fine, right? So it's whether it's like a plumbing issues, we have some signal that there might be some hypovolemia involved. In my mind, in general, like those are tends to be the most common. So whenever I see an AKI, assessing the volume and also just like making sure the bladder scans are fine, you're not dealing with post-renal, because again, the management is so different. If there is a post-renal etiology, whether it's like putting a Foley in, or you have like bilateral ureters that are compressed, whether that is by lymphadenopathy or by stones, then that would require urology consultation. So thinking about just getting your ultrasound to make sure that's not contributing. The other thing you can sometimes get a clue on is your other electrolyte. As you mentioned, potassium is on the side, is like 5.5, is a bit on the more elevated side. So I agree. I think I would be closely monitoring that potassium. And oftentimes one thing that I've always noticed in the post-renal pathologies tends to kind of, because it's like obstruction, the potassium tends to shoot up really fast. So the fact that is like a upper limit of normal is definitely worth keeping an eye on and potentially thinking about treating it. In terms of like the one thing that I always like make sure whenever I see an AKI is just like make sure to review the med list, that there are so many medications that might not be the culprit but contributes in making AKIs worse. So you want to like pause those medications, stop those medications, dose adjust medications that the patient's on. So whenever you see a severe AKI, definitely running the med list with the pharmacist to make sure everything is dose adjusted. In terms of like, the degree of elevation, if this is acute, as you mentioned, really intrarenal pathologies are the one that jumps out the most. And with the intrarenal pathologies, thinking about what part of the nephron or what of the system is affected, is it glomerular, is it tubules? Tubules tend to be the most sensitive. I always think about them as like the workhorse of the kidneys. So they're the most susceptible to ischemic injuries, or the most susceptible to pigments, most susceptible to anything that can damage it. So tubules tend to die off, and that's ATN, whether it's interstitial etiology or a vascular pathology. And oftentimes like a UA is very informative, having renal spin the urine to see if we see any muddy brown cast, do we see dysmorphic reds. The one that is oftentimes we don't catch it in the UA is the ones that are far away from the apparatus that makes the urine. So those are your vascular pathologies. Interstitial disease oftentimes is hard, but I think like so far, my focus, if I'm evaluating this patient, is to try to understand what is causing the AKI. And then as we gain a better understanding of which buckets we are, then kind of taking a step back and see like, oh, is the whole GI symptoms red herring, or is there a link between those two that we need to investigate a little bit more? Any other thoughts, Jema?
I have to say, I now see that the patient had a recent travel and was walking in the woods. And because I love ID, when I try to connect these kind of kidney symptoms and in the woods, I mean, you could think of, I mean, in terms of tick-borne, I mean, I was thinking of something like something like that can present with AIN. So I was thinking of, if it's not tick-borne, I was thinking of Legionella hantavirus can present with that. So that can present with acute interstitial nephritis. And otherwise, let me think. There was another bug that I was thinking of, but it doesn't come into my mind at the moment. But I should remind. Legionella hantavirus. Leptospirosis is also in my mind. Always think of that. Yeah, but I'm excited what Andrew is going to tell us more.
I'm so glad I have an AD expert here with me because I would not be able to come up with those. All right, Andrew, mic back to you.
Awesome first discussion. So to quickly review the southwest corner of the whiteboard, her past medical history was notable for very remote Hodgkin's lymphoma treated with an unspecified chemotherapy and whole body radiation. She had a splenectomy and complete hysterectomy. She has hypothyroidism on levothyroxine. She has hypertension on lisinopril. She has vitiligo. She had no allergies, and she's up to date on her mammograms and pap smears. So going back to this index hospitalization, the labs were already as mentioned. The UA was notable for a few RBCs, no protein, no white cells. A CT of the abdomen without contrast showed bilateral mild hydronephrosis. Urology did not feel there was a need for intervention. She was aggressively hydrated and her creatinine plateaued without a true decrease. So that is the AKI issue, and this is where things kind of split. I'm going to give you a bit of a twist for the case that you're going to have to keep tracking. So additional history was notable for left leg pain, for which a duplex ultrasound was done, showing a DVT in the left femoral vein and both perineal and posterior tibialis veins. So going back to the abdominal CT, there were incidental innumerable sclerotic bone lesions throughout the skeleton. No intra-abdominal mass was identified. The CT chest showed more bone lesions extending to the head and neck. There was no pleural effusion or pulmonary mass identified. And then regarding lymph nodes, some were calcified, but none were called as pathologically enlarged. And that's the end of this aliquot.
Awesome. So just to make sure, Andrew, I got it. The AKI resolved, which is fantastic. But it sounds like she has a DVT and also bone lesions that was found. Incident.
And sure, I mean, the creatinine like plateaued, like it stopped going up, but it didn't get better.
Gotcha.
Yeah. And yeah.
Wonderful. Thank you, thank you, thank you, thank you. All right. So Seyma, love a good twist. So I've never passed on the opportunity to think about AKI. So thank you, Andrew, for that. So what are your thoughts now on the DVT, the fact that the creatinine was plateaued, and what do you make of the bone lesions?
Okay, so first of all, the DVT was acute, Andrew, just to make sure.
Yeah, all signs pointed that it was acute.
Okay, so basically I'm asking myself, if this was if the DVT was diagnosed on imaging, I am assured that this is DVT, because if it was only diagnosed clinically, I would just like to make sure that this is not something dermatologic like an erysipela or cellulitis, but I think it was on imaging, right? Okay. Then basically looking into the past medical history, the patient had Hodgkin lymphoma, also splenectomy, and was on chemotherapy. I don't know when the patient had the Hodgkin lymphoma, because I'm always also concerned of a relapse in a patient like this, also with these sclerotic bone lesions. I mean, typically with Hodgkin's lymphoma, bone metastases are possible, but I would have to look for how these bone metastases present, because sclerotic bone lesions is what I associate with sclerotic bone lesions more if it's like osteoblastic metastases. Sometimes there are systemic diseases like mastocytosis that can present with sclerotic bone lesions. So that's one of my differentials for it. Otherwise, with the splenectomy, the patient is at risk for encapsulated organisms, just to keep that in mind. I also don't know when the chemotherapy was, just to make sure, because we know the patient is at risk for several infections. And with the, as you said, the patient had vitiligo, also has hypothyroidism. And I have to say, I don't know whether there was also any other endocrine disorder, but whenever I hear vitiligo and an endocrine disorder, I'm always concerned of these autoimmune polyglandular syndromes, just to keep that in mind. Another thing that came into my mind, I don't know whether POEMS is able to present with sclerotic bone lesions, but in my head, it was also one of the differentials, but the patient doesn't have polyneuropathy that is important for it. And with this age, I mean, with 64 years of age and the prolonged fatigue and bone lesions, usually we would also think of, I mean, malignancies that can manifest in the bone, but like, for example, like multiple myeloma, but this is not a disease where I would expect sclerotic bone lesions, rather osteolytic lesions. So yeah, and otherwise, with the DVT, the question is, we know there are several risk factors why someone can develop DVT. If there is stasis, any kind of hypercoagulable state. With the Hodgkin lymphoma, I have to say, I usually associate more solid tumors like pancreatic cancers with higher risk for DVT, but malignancy puts this puts the patient at risk for DVT. And yeah, that's what I'm thinking so far. What do you think, Sharmin?
Yeah, beautiful. Multiple things to track, right? So the three things that we're kind of tracking is her renal failure, this DVT, and this bone lesions. And again, as you're doing, I would like try to make progress on those three and then see if there's a unifying factor. There might be, there might not be not. Out of all those three, if you ask me, I would just put the DVT a little bit to the side. Mostly because, okay, like the DVT, as you mentioned, right, like it's either hypercoagulable states, and malignancy is already on our radar because of the bone lesions and her past history. And the other thing, she has recently traveled, and whether this is like provoked, unprovoked, all those great things, we can just like come back to it in a little bit. And then I still want to know why this lady has a kidney failure. Those are the two things that I would have as my primary focus while kind of keeping track of the rest of the things. And as you mentioned, I loved your differential about the bone lesions. Couple of things are like, is the bone lesion related to the renal failure? Is it like getting a PTH? Let's see what that shows. And then whether this is like kind of primary bone lesions or secondary. And I think in the secondary, you're absolutely right, given the DVT, given her prior history, malignancies are the one that comes to mind. And thinking about like, lung that likes to go to the bones, thinking about lymphoma relapse of it. Multiple myeloma is a one to consider in a setting of like, oh, someone who has like kidney disease and bone disease. I didn't, I think the protein gap didn't seem very, it didn't seem like a big delta to me. However, I would get the SPAP, the UPAP, all those good stuff to further evaluate that. And I think like there's, in terms of like, and lymphoma that you already mentioned. So both like thinking about the hematologic and solid tumors, and yes, the infections can cause like osteomyelitis and all of those things. However, again, like I think I would worry more about kind of malignancy. However, never wrong to get blood cultures. And in terms of like a renal failure, the UA wasn't very impressive. I like to trend my UAs like I trend my troponins. So just to make sure that sometimes you just don't capture the disease. So repeating it makes good sense to me. And then I think the question is with that mild hydro, why this patient has mild hydro? Is the size of the kidney small? Is there a component of chronicity to this kidney disease? Or is there some lymphadenopathy or something that is causing a little bit of a compression of the ureters and causing mild hydro? And repeating the UA, getting your the UPAP, the SPAP, the immunofixation. And the other question is like, is there any concern? I know she was on lisinopril before. That's I think probably is being held, most likely contributing a little bit. But again, I think this is disease process that can't just only be contributed to meds, and whether at some point like a kidney biopsy would be helpful to help us make more progress. And that's the question that I would be asking our kidney disease, especially because with the DVT, we're going to have to start her on anticoagulation. And is there anything we can go after, whether it is the bone lesions or the kidney, to help us like make more diagnostic process? Or would be the questions that I would be discussing. Any other thoughts, Shema?
Yes, I was also thinking with the bilateral hydro, that's an unusual constellation. I mean, where several processes I associate something like Almond's disease. So if you have retroperitoneal fibrosis, I know you can have this in IgG4 related disease, but there are sometimes also other constellations that can provoke this. The patient had whole body radiation. I'm not sure whether this can cause this, but I don't think that this is unlikely because late toxicities of radiotherapy tend to present with fibrosis. So I don't put this into an unlikely category. Otherwise, other histiocytic diseases just came into my mind, like airtime Chester, that can also present with these hairy kidney signs. And also I think sclerotic bone lesions. And with the whole body radiation, that was also an alarm signal for me, just to make sure they can induce secondary malignancies. And as other people mentioned in the chat, this patient could have also developed something else like breast cancer that also can, because breast cancer is a malignancy that loves the bone. That's like one of the first things we have to stage when a patient is being diagnosed with breast cancer. And other cancers like thyroid cancer can also present secondary to a radiotherapy. So yeah.
That's just brilliant, Shema. That was absolutely brilliant. Yeah, it's quite interesting because the other thing that as you were elegantly discussing came to my mind was like kind of hemoglobin of 15. Again, like someone who that is also normal hemoglobin in someone who has like multiple things always captures my attention. There's part of it that might be dehydration because of the gastroenteritis diseases that she had. And part of it could be, again, like thinking about like, is there any threads that you can pull? Is like renal malignancies oftentimes can have like kind of abnormally normal hemoglobin with them because of the paraneoplastic syndromes. Are we dealing with like a malignancy with paraneoplastic syndrome that could potentially explain that? With multiple myeloma, you would assume anemia as part of the disease progression. However, most diseases don't read textbooks. So I think I would still keep it on the differential as well. But yeah, interesting pattern. I'm very excited to hear more, Andrew.
Oh, you two are masters. I can definitely give you guys more info. So since the creatinine plateaued, she was at this point discharged from that hospital with close renal follow-up. A battery of labs were sent for the renal dysfunction in the clinic setting and notable for a negative ANA, double-stranded DNA, complements, antiphospholipid antibodies, HBV, HCV, ANCAs, and anti-GBM antibodies. SPAP was sent, showed no monoclonal protein. There was no serum immunofixation, but they did send the free light chains. The ratio was normal at 1.1. A bone marrow biopsy was performed for her bone lesions in the outpatient setting. That was normal. She also noted an enlarging mass over her scalp, for which she saw dermatology for biopsy, and this showed what's called a porocarcinoma, which is a skin tumor of the sweat glands. A PET scan was done and showed the bone lesions were all PET avid. None of her visceral organs were pathologically avid. In the interim, her fatigue is then joined by anorexia and malaise, and repeat labs showed worsening creatinine to 11, for which she was told to go immediately to the hospital. A renal ultrasound this time showed moderate bilateral hydro that extends only to about midway down the ureters with normal distal ureter caliber. Urologists consulted and recognized that our intrarenal AKI workup is negative and there may be some concern for retroperitoneal fibrosis given our whole body radiation, for which they take her for a cystoscopy where they place 2 ureteral stents and take a biopsy, which does show fibrotic tissue in the ureters. And that's this aliquot.
All right, Shema, what do you think?
So now seeing this new skin tumor of sweat glands on her scalp, I mean, I have to say, I'm a bit wondering about this because this is a very rare skin tumor. Like more commonly, if a patient is being immunocompromised, there are other skin tumors that I associate with it, like squamous cell cancer is like one of the most common cancers you would expect in an immunocompromised patient. So yeah, I have to say, my knowledge for porocarcinoma and how, in terms of how aggressive it is very limited. So you would have to help me. And otherwise, seeing this retroperitoneal fibrosis, that could be explaining the patient's AKI, but I have to say I'm currently struck because we have so many pertinent negatives. The intrarenal workup is negative. We have an explanation for the hydro, and now this patient has, I mean, and as I understood, the bony processes came out negative, so we don't have any a hint that this might be malignant, but otherwise, yeah, I have to say, I need a little bit help from you, Sharmi.
Yeah, this is complicated, and I'm sorry I can't help you with malignancy. I don't know much about that. Maybe Andrew can teach us a little bit more. But I think that's something that I would look up, right? Like, is a malignancy that I have come across, and the question is like, is this a kind of a focal? If it's like sweat glands are involved, then does it mean that it has a tendency to metastasize? What that would look like? And I think that's something that honestly I would just read up on and also just get our friendly dermatologist and ask all of my questions. So that's what I would do because I don't know. I don't know how it would relate, but I think it's definitely a good thread because it's a pertinent positive for us to make sure that that is not something that is contributing to her presentations. I think it's fair to say that given her whole body radiation, she's at higher risk of fibrosis, and that's the fact that it's progressing to me is interesting. So the fact that it went from like mild to moderate hydro. So the question is like, and to me, like radiation is a diagnosis of exclusion. So what else could cause this type of like fibrosis? Any thoughts, Shema? Like anything that comes to your mind?
Since you were also thinking of IgG4 related disease, I would definitely try to, because sometimes you have to do multiple biopsies and also would check the IgG4 levels. And I would be curious about the pathology because with IgG4, we would have expected a lymphoplasma cellular infiltrates of eosinophils, and especially with the histiocytic disorders that we mentioned. I have to say, I would try to make sure to stain for S100. Also, I think it was CD163. So these, the typical markers for these typical, for the histiocytic disease. So would be curious whether there was a workup for it and whether any kind of granulomas or giant cells were seen.
Yeah, beautiful. And the fact that you know the staining pattern, Shema, that's absolutely brilliant. I'm like, I don't know. that was fantastic. Yeah, I agree. I think the question is, so we have a bone biopsy and now we have some renal biopsy. And part of it is always like going back to pathology and asking like, hey, for these presentations, I'm worried about IgG4. Clinically, I'm worried about like histiocytic diseases. Is there any clues? And sometimes like, the staining might be different. The pathologist that looks at the slides could be different. So oftentimes like reviewing the pathological slide or thinking about getting additional eyes on it, and also like getting an additional sample might be helpful because what we know is that her disease is progressing, right? And so the question is like, now if we repeat a biopsy, we'll be able to catch something that we couldn't have a few days ago or a few weeks ago when as her disease has progressed. And I think yes, like you said, acidic disease, I think malignancy is still, I'm suspicious, is really, really good at hiding. And as you mentioned, like IgG4 disease, then I have to like think a little bit more about like what other disease would cause this type of fibrosis pattern. I think like I think HCV was negative. Cryo diseases, I think, are less likely here as well. So I'm right there with you. I think the answer still probably lies in the kidneys or the bone lesions. And the other thing to think about is like, are there two separate processes that is going on too? As we try to link these two together, we might get into trouble. So still like keeping those two separate in your mind as you're working it up. And the other thing that I was like thinking about, like, with pet avid, any infections that could cause it, those tends to be very sneaky as well, especially like more indolent infections. As you mentioned, I think like given her travel histories, those were worthy to a revisit too, just to make sure, we're being thorough in our workup. Any other thoughts, Shema?
I have to say, when we were talking about IgG4-related disease, I was also trying to think what makes it unlikely. I've heard that the complements were normal. I usually associate IgG4-related disease rather with low complements. And also, I would be quite interested in the differential too, because I learned from Ravi, patients of IgG4-related disease tend to present with eosinophilia, or they sometimes have these kind of atopic stigmata. So that's one thing that I would keep in mind. And otherwise, as you said, for infections, causing this kind of fibrosis pattern is rather usually for atypical bugs, so these granulomatous. But yeah, I'm curious what Andrew is going to tell us.
Oh, such a good discussion. So I'll answer some of the kind of thoughts that came up. I actually hadn't included this. I forgot, but I'm glad you mentioned it. So IgG4 levels were sent and were normal before I came on service. The ureter biopsy did not show any sort of histiocytic infiltrate, but they didn't immunostain it for S100 or anything. And then for more IgG4 stuff, she didn't have any like atopic symptoms, and there was no peripheral eosinophilia. So the two stents, the ureteral stents, they work. Her creatinine comes down rapidly and she begins to slowly feel better. And this is actually when I meet the patient, which is perfect timing because now we have time to redress the bone lesions. No primary pathology has been determined at this point. So I retook a full review of systems beginning when this creatinine business started. And she's adamant that other than the brief GI illness, the only major unexplained symptom she had was spontaneously high thirst. She just described feeling thirsty all the time, which she said was weird because she was never someone who drank a lot of water. Her sodiums through all of this were hyponatremic through all of this though, like because she was in renal failure. She's very familiar with B symptoms because she's a former Hodgkin's patient and she denies these symptoms adamantly too. And that's the end of this aliquot. And then I have one more aliquot before the final diagnosis.
All right, Shema, what do you think of the increased thirst and the rest of the information?
With the increased thirst, I would be curious whether the patient is also having, I think, okay, I wanted to say I would have expected also polyuria but the patient had a problem with the kidney. So I think that there was maybe a problem why the patient couldn't urinate. So because otherwise, if there was a constellation of increased thirst, usually when I hear someone is increased thirstiness, I think because someone is losing a lot of water because they're dehydrated, because, for example, if you think of someone who is hyperglycemic, so I would be curious whether the patient, how the metabolic status of the patient is in terms of the glucose was normal, okay. Otherwise, what I could imagine with the increased thirst, I mean, the sense is, I mean, it is being registered in the hypothalamic area and through osmoreceptors, and usually I think, I don't know, with the whole body radiation, I don't know whether the patient had also radiation on the brain area. Sometimes it could have secondary to radiation, a problem with the hypothalamic area that is responsible for that. And then I don't know, a patient might present with something like diabetes insipidus, and then this patient might have a higher sodium usually, but I see the patient has hyponatremia. Okay, this could be also, I mean, an explanation for something like secondary. I mean, for the hyponatremia, I would like to work this up to see, because sometimes secondary to radiation, you could develop something like SIADH and also like could be paraneoplastic. But I just want to make sure where this hyponatremia is coming from, because when I look into the drugs, I don't see a culprit. And otherwise, if we go to our typical hyponatremia bucket, we have to make sure whether this is true hyponatremia. So look into the serum osmolarity, whether we have, is it hyperosmolar, so true hyponatremia, or how are the lipids? We saw that there was no sign for paraproteinemia, as I remember. And otherwise, sometimes you also have to look for, I mean, the patient is not consuming a lot of alcohol, that might also sometimes interfere with it. And then if we know that this is a true hyponatremia, I would also like to ask the patient how much water the patient is drinking, because if I read the patient is thirsty, sometimes you can have something like psychogenic polydipsia, or if patients drink more water, then the kidney is able to excrete. Of course, you will tend to have hyponatremia, but yeah, what do you think, Sharmin?
Yeah, I think it's quite complicated because yes, whenever you think about like increased thirst, like think about like dry mouth, as well as I always like pair that with like asking like prior to her kidney disease about urination. Is she urinating a lot as well or not? And I think the complicating factor in this case is because she had the renal failure. Those can like work against each other. And like if she's, and now her kidneys are getting better, most people have like a little bit of a post ATN diuresis as well, which also complicates the picture a little bit more. So sometimes with that, you have to let the dust settle to see where she lands, to see like, oh, is this really again like a red herring, or is it truly a signal? The 5 carat sodium, when she came in with like the renal failure, was like 139. That is like impressively normal for someone with the pathology that she's presenting with. So it could have been there was a signal for diabetes insipidus. And when I think about nephrogenic versus like central, like whether she has a central component of the disease, I agree. You always want to think about meds as well, or if there is like a nephrogenic cause. And like infiltrative diseases like histiocytes tend to like those things as well. So I again, like I think like infiltrative diseases are the one that kind of help in my mind can tie those together, but I'm not 100% sure. Any other thoughts, Shema?
I mean, when we were thinking of something like diabetes insipidus, the only thing that, made it a little bit unlikely for me, I would usually expect the patients to be hypernatremic, but if the patient is drinking so much and if they also have some kind of kidney failure, maybe this could masquerade it, just a hypothesis. And otherwise, whenever I hear diabetes insipidus, sclerotic bone lesions, and the kidney process, and something like fibrosis, as we said with infiltrative diseases, something like Erdheim-Chester comes into my mind just as a hypothesis. And otherwise, there was something else I wanted to say, but I don't remember anymore.
Now, brilliant. You're so brilliant, Shema. All right, Andrew, tell us more, please.
You guys are doing great. This is a very, very complicated case. I can't wait to debrief after. So this is the last aliquot before the final diagnosis. So due to all of your concerns for potential pituitary disease, because that's what she gave us, with a combination of increased thirst and retroperitoneal fibrosis. I actually shared this case with Kurtan. We were texting about it, and he encouraged me to go ahead and send an MRI brain on this patient. I was like, yes, that sounds like a good idea. I trust Kurtan, and I see where we're going with this. That showed pachymeningeal thickening and enhancements and absence of normal T1 signal in the posterior pituitary, which can be either a normal variant or associated with posterior hypophysitis, according to the radiology report. So in going back to the PET CT she had gotten a while back, just you can take a look and see where exactly these PET avid lesions were. A normal PET scan cuts off like above the knee, I believe. And they did not see any symmetric avidity in the long bones of the distal leg, basically where the scan cut off. So it was not a whole body PET scan. Just wanted to let you know there was no symmetric PET avidity. At this point, I did a full skin exam, and she did have a back nodule that we can biopsy. So before moving on to what we did next for the final diagnosis, I'll just pose you the question I face. What tissue would you like here? We have an already diagnosed porocarcinoma of the scalp, now a back nodule of unclear significance, and the bone lesion. So I'm just curious what you would do in real life here, because this was really the challenge I faced.
I think I would take the nodule on the back at the moment because I'm curious because we don't know what it is. But yeah, just a question. Should we comment on the imaging findings or do you have another question, Andrew?
Oh, that's everything for you, Shayma.
Okay, because when you mentioned pachymeningeal thickening, I was reminded by a discussion by Dr. Dhaliwal. He said, whenever you hear this, first things is you would think of histiocytic diseases. For example, sarcoid, IgG4 related disease can present with that. Also, TB can present with that. So any granulomatous infection. And also, I think he mentioned something like intracranial hypotension can also manifest with pachymeningeal thickening. But in this whole context, I am more concerned of one of these histiocytic spectrum diseases. And for this back nodule, Andrew, is there any description how it looked like, or
It wasn't ulcerated. It looked like a little pink. It was firm. That's the most dermatologic I can get with it. It didn't look very crazy. It just looked like a small pink nodule, I would say.
I mean, I would always say the tissue is the issue. I would get some biopsy from it because, as you said, we didn't have any. I don't know how much of info I will get from a bony biopsy, and it's more of an invasive process. And whenever you have I mean, with the skin nodule, I mean, with a skin nodule that looks suspicious, I would also ask the patient, what's the first time you ever noticed this bump or nodule? I mean, the time progression can give me a kind of an insight. Is this more malignancy? Because there are several malignancies that tend to grow very fast, like if something like macular carcinoma, or even if it's a melanoma, so like amelanotic melanoma. But I have to say, I mean, I don't know the time course, but of course, I have to say, I still haven't excluded a malignancy because, as I said, for example, with melanoma, especially amelanotic melanoma, that really tends to grow very fast and tends to metastasize everywhere. But one thing that makes it unlikely for me, the whole stainings that you did, the pathology. So yeah, what do you think, Sharmin?
Yeah, I agree with you. Often when I think about like biopsy, I think about like benefit versus harm. Like, what is the easiest, most accessible? Like, skin biopsies tend to be like low risk. It's there, can do it. So I think like skin biopsy for sure. I think the fact that whether I would want to go again after bone or not, I think will depend on where was that bone lesion taken from, and kind of like going down to the radiology, looking at PET CT and thinking about the PET avidity of the lesions, and whether is there any other spaces that are easily accessible that would give us the answer to that. But I think that would be kind of like my thought process. Start with skin, review the PET scan, and see if it makes sense to go for another bone lesion if it's a more PET avid. I agree. Like, I think like the histiocytic, more infiltrative diseases are the ones that I would worry about. The other one was like, are we missing anything from the autoimmune categories? Like, given her history of Sjogren, increased thirsts, like, guess a signal to that. But again, like Sjogren's can have weird presentations as well. So I would start with those two and then see if that gives us an answer. Andrew, what did you all do?
Oh, I'm so happy I presented the case to you too. Thanks for playing along with this super challenging case. So I'm gonna go on a bit of a pedestal for like 5 minutes so everyone like get some water and just chill out for a
Oh
little
my gosh,
bit.
I am
That's
so excited. I love Andrew pedestals. Go for it, friend.
Okay, so 2 biopsies were performed. One of the back nodule, given its availability, dermatology said it's there, so why not, since the suspicion for histiocytic disorder is so high. But then also one of the bone lesions still 2 weeks later. I wanted to do that in case the skin nodule was just completely benign and unrelated. And in the instance it wasn't helpful, we still needed tissue. To putting you in my headspace, when the prelim path from the nodule came back non-suggestive of histiocytosis, but the bone path had yet to be performed, there were 2 possibilities to me. One, there's still hope this patient has histiocytosis. She may have 2 different skin tumors due to a high mutation burden from her whole prior body radiation. In this instance, her bone lesion may still show histiocytosis, and she simply has 1 or 2 skin primaries. Or 2, I'm dead wrong. She just has metastatic porocarcinoma. So the back lesion showed a poorly differentiated carcinoma with focal ductal features and mucinous stroma. This really eluded our pathologist, who felt it could be esophageal, HPB, breast, or thyroid in origin based on the immunostaining. But our PET scan did not show any primaries consistent with this. In comparison of the back nodule tissue features to her original porocarcinoma, which we actually had to get from another institution, was actually similar enough to presume the unfortunate final diagnosis, which was metastatic porocarcinoma. So some points on porocarcinoma. This is an extremely rare tumor that occurs most often on the head and neck or lower extremities of older individuals, the mean age of 68. The sex distribution is equal, and large tumor size, like greater than 4 centimeters, which hers is almost that size, is associated with a poor prognosis. Mets are detected in 20 to 30% of patients at presentation, with most Mets occurring in the lymph nodes, the most common site, or the lungs. Chemotherapy has been used for treatment, but case reports of immune checkpoint inhibitors have shown patients can achieve remission with agents like Pembro. So some points on the journey here, which I think is the most important part. So this case is called Occam's versus Hickams because how can a patient with progressive renal failure from bilateral retroperitoneal fibrosis, osteosclerotic bone lesions, and a porocarcinoma be tied together? So Hickams' dictum states a patient can have as many diseases as he damn well pleases, but what does this mean? There was an excellent clinical reasoning paper just released that tried to answer this question, and the authors analyzed a large series of CP-solving publications for patterns that would basically elaborate on this non-specific saying. And what they ultimately found is neither Occam's nor Hickams is really adequate to understand the different relationships between multiple diagnoses. What they instead emphasized was the use of temporal relationships to elaborate on 4 ways a diagnosis can relate to the finding you were observing at the time point you're intersecting a patient. So first, they consider a finding can be temporally disconnected, representing a disease of the past. In this case, unless you're observing a complication or flare of a past condition, the relationship between your patient presentation and prior disease is less likely. Second, they consider all findings you're observing during a patient encounter can be complete coincidences and unrelated to the symptoms at hand. In other words, consider incidental findings, which are not uncommon. Third, they consider diseases that are completely unrelated to one another, but concurrent, and that they present at the same exact time with acute symptoms. And this is a highly unlikely event, and you can visualize this by basically taking the probabilities of individual diseases and multiplying them together, and that's what you get. And the last category, and one you should really think of up front, is that the last category and one you should think of up front is that findings are causally related to a proximal unifying endpoint diagnosis. And when this is the case, the occurrence of one disease increases the probability of another. So think about a patient hospitalized for pneumonia. The presence of pneumonia and hospitalization increases the risk for PE and C. diff colitis. So I agree with the author's point. This framework generally reflects how we intuitively reason through cases, as we do generally look for how findings are related to an acute presentation before we consider incidental findings. But having this concrete framework is helpful to have that on paper for cases like this. So in this case, the retroperitoneal fibrosis ended up representing a complication of a historical element, actually, which is the Hodgkin's lymphoma radiation. So what we were observing at our index presentation was just post-renal AKI related to that. The remaining cancer findings technically ended up being complete incidentalomas, really, because other than the one incident of bony leg pain she had, the cancer wasn't really driving symptomatology in her. So I finally wanted to share a personal growth point based on how I communicated the uncertainty of this case with the patient while we were waiting biopsy results. So something we learned in med school is never to provide a cancer patient a diagnosis without tissue. kind of broke that rule here, and this will always kind of haunt me. To me, the clinical findings of this case were so specific for histiocytosis. I actually had the patient watching YouTube reviews of Erdheim-Chester disease. I did explicitly tell her several times I could be dead wrong about this, but I wanted to give her a glimmer of hope for good treatments to come as she was in a pretty helpless place. But when I later called her to give her the bad news, she was thankful for the hope I provided her. But humility is really what I'm left with, and I'm not sure I'll like take a patient down that sort of road again. And those are all my thoughts.
Andrew, you're awesome. You're just awesome. Thank you so much for sharing that and for all the amazing reflections. And I totally agree with you. I think as much as I love like these spaces reflecting on cases, being there in real life, it's something totally different. And having to grapple with the uncertainty and the different timing of that, how you communicate to the patients. And I often think at the end of the day, being your most genuine self with patients and also reflecting with them, and that's what people respond to. And I think the fact that uh, I you have the humility to look back and say like, oh, that didn't go as well as I wanted to, and how I can improve and how I can be better after that, I think speaks volume to the way you practice medicine, and that's deeply inspiring. And yeah, what you mentioned about clinical reasoning is exactly what I love. Clinical reasoning is like how these puzzle pieces fit together. Do they not? Are they separate? Are they connected? Are they happening at the same time? Are they different diseases? Like, I think that's what I find most rewarding in thinking about diagnostic reasoning and clinical reasoning is like how these things can be totally related or unrelated to each other, and how we get to practice and learn and grow. And carcinoma, I've never heard of it. So thank you for teaching me something new and helping me becoming a better doctor, and also taking moments to reflect on cases. And I hope we get to do more of that together. Shema, any reflections?
First of all, thank you so much, Andrew, for this amazing, very humbling case. I have to say that really taught me so much, because it again shows you a patient could have multiple processes ongoing at the same time, and we don't always have to be attributed to one disease ongoing. And I think that this case was a great reminder for that. And also, thank you so much for bringing a porocarcinoma case. That was like one of the skin tumors I said I am skipping, but that was a very amazing opportunity to learn about its yeah, how it can manifest. And thank you so much for the one and only Sharmin. I couldn't have imagined a better discussant on a Wednesday here. Thank you so much.
Shema, you're so brilliant. Like when I was in your shoes, I was not even half. I was like 1/3, not even 1/3, 20%. That's good. So it's just amazing. Your knowledge, your humility, like it's just, I mean, I'm always in awe of you. Beautiful job, friend. Thank you so much, Andrew. Your cases have always been amazing, and I've always walked away learning so much and grateful to be in these spaces. Thank you so much, Rahul, for scribing, and we are ready for you.
Yes, thank you so much for a great case. I learned so much. Also, for a 64-year-old female with fatigue is really non-specific, so we focus on creatine 6.5. We were thinking about, I'm sorry, chronic kidney disease or acute kidney disease, so like a pre-renal and post-renal and intrinsic, looking for ultrasound for obstruction or review the medication, or if it is possible, stop the medication. And past medical history shows a lot of hint for us. Hodgkin lymphoma labs or sclerotic lesion, IgG4 disease, or it could be breast cancer metastasis and splenectomy causing the encapsulated organism infection, vitiligo linked to the APS, and DVT hypercoagulable malignancy or travel-related. And another one, bilateral hydronephrosis with high creatinine suggests the obstruction. And we also thought about causing the radiation fibrosis is causing that. And high hemoglobin could be the cause of dehydration or tumor. And in retroperitoneal fibrosis, we consider about IgG4 disease with peripheral eosinophilia and histocytic disorder, evaluate marker with the CD68 or SN100. It was really great for SEMA. And granulomatous and skin tumor, we have to consult with the dermatology. And hyponatremia thirst, we are thinking about so many things, but maybe it could cause of DI nephrosensory disorder, and we ordered the MRI and causing the parenchymal thickening. And we also consider about, again, histocytic disease and granulomatous disease and malignancy. And the answer for the diagnosis was the metastatic procarcinoma of the skull. That's it. Thank you so much.
Brilliant, as always. It's just always amazing to see you all just distill the case down to such great teaching points. Thank you all so much. I'll be thinking about this case for the rest of the day. So thank you so much for joining us. We really appreciate you. Have a wonderful rest of your day. Bye.